Hi, everybody. We're letting folks filter in for about a minute or two here, and then we'll officially get started. So we'll be back with you in about a minute or two.
Versa. You simply could exercise.
Good afternoon and hello again, everybody. My name is Stephanie Dugan, Communications Director for the Pennsylvania Department of Drug and Alcohol Programs. So I want to thank you so much for taking your time to join us today and your interest in this webinar. So we have a full hour ahead planned for all of you. So I'm just going to briefly go over a few housekeeping items, and then I'll set the stage for what you can expect as an agenda for the next hour as well. So housekeeping is number one, please note that this session is being recorded for the purposes of having on-demand availability after the fact. So by participating in this session, you are consenting to the recording, retention, and later use of it. Number two, we will be holding the Q&A portion after all the presenters have gone. But you can feel free to put your questions in the Q&A panel anytime throughout the presentations. The Q&A panel should be at the top of your screen, right to the right, direct right of the chat feature. So at any point, again, prior to the Q&A, you can go ahead and put those in there. And even better, if you can make a note as to which presenter you want your question to be directed to. So those are the two main housekeeping items. And then today we are joined by experts in the field of words matter in the substance use disorder space in varying lines of work. So first, you're going to hear from our partner in the development of this webinar. And those are the folks at Penn State Harrisburg's Douglas W. Pollock Center for Addiction Outreach and Research. Dr. Weston Kensinger and Erica Saylor will be highlighting the Life Unites Us anti-stigma campaign and how it's changing minds, attitudes, and behaviors regarding SUD stigma. They'll also outline how you can use it as a resource going forward. So after them, you're going to hear from Ashley Narvaez, she's from the national organization called Shatterproof, and she's really going to get into what words and phrases are stigmatizing and alternatives that we encourage all of you to use going forward. And then we're going to round things out as far as presenters with Hannah Webster. Hannah is a reporter from the Pittsburgh Post-Gazette who regularly reports on the opioid crisis and substance use disorder. So she's going to offer best practices and a bird's eye view of how to report on these sensitive topics. So with that, I'm going to turn things over to the Department of Drug and Alcohol Program Secretary, Dr. Latika Davis-Jones, to officially welcome all of you to today's webinar. Secretary?
Yes, good afternoon, everyone. As mentioned, I am Dr. Latika Davis-Jones, Secretary at Pennsylvania's Department of Drug and Alcohol Programs. I'd like to officially welcome you to today's webinar, right? Thank you all for being here. This webinar is taking place during the Heart of Recovery Month, which is being celebrated here in Pennsylvania and across the country. Recovery Month reinforces the positive message that behavioral health is essential to overall health. And it is also essential to the fact that we know that prevention works, treatment is effective, and people can and do recover. It also amplifies the message of how we must all work together to reduce the stigma that is still attached to the disease of addiction. Which brings us to why we are here today. Language. Language has the power to heal and the power to harm. It is my hope that within the next hour, we will be able to make your lives a little bit easier when it comes to writing about, talking about, and reporting on the disease of addiction and your own stigma reduction work. With that, I'd like to turn it over to Dr. Weston Kinsinger and Erica Saylor with Penn State Center for Addiction Outreach and Research. Thank you.
Great. Thank you, Secretary Davis-Jones. Good afternoon, everyone. Thank you for taking the time to join us today. The overwhelming amount of individuals that registered for and signed on to this webinar illustrates just how important reducing stigma related to substance use disorder is. As the Secretary mentioned, my name is Dr. Weston Kinsinger, and I'm the Director of the Douglas W. Pollock Center for Addiction Outreach and Research at Penn State. It's a privilege to speak with you today about the Life Unites Us campaign. As the principal investigator for this initiative, I've had a front row seat to its development and impact, and I'm excited to share our journey with you. So what is Life Unites Us? Life Unites Us is Pennsylvania's statewide, evidence-based public health campaign designed to do one primary thing: reduce the stigma associated with substance use disorder. We know that stigma is a significant barrier that prevents individuals from seeking life-saving treatment and isolates families who need support. This campaign is our response. It's a large-scale collaborative effort, bringing together the expertise of researchers at Penn State, the strategic communication of the Public Goods Projects, and the national leadership of Shatterproof. Most importantly and most critically, this work is funded and done in very close partnership with the Pennsylvania Department of Drug and Alcohol Programs. To tackle a complex issue like stigma, we need a clear, multi-pronged framework. Our approach is grounded in a classic public health model focused on three sequential goals. First, we target knowledge. We educate Pennsylvanians about the science of addiction, and most importantly, to reinforce a hopeful, evidence-based message that recovery is possible for everyone with the proper support. Second, we address attitudes. By increasing knowledge, we aim to improve public attitudes towards our neighbors, colleagues, and family members who are living with or who are in recovery from a substance use disorder. And third, we focus on behaviors. We want to empower Pennsylvanians with the confidence and self-efficacy to seek and engage in treatment options for substance use disorder and continue into recovery. Further, the campaign works to encourage others to provide support to a loved one with a substance use disorder. This means moving people from passive awareness to active allyship. This diagram illustrates the campaign's operational engine and outputs. It's a continuous, dynamic cycle. Everything begins with research and evaluation. We conduct literature reviews, statewide surveys, and in-depth interviews to understand the specific nature of stigma in Pennsylvania. These insights are crucial as they directly inform the key messages and creative strategies for all of our public digital stigma reduction activities. These include our social media components, our work with influencers, and our website, which house a powerful story library. In parallel, we run a robust partnership doing collaboration and education programming, which includes webinars like this one, monthly email newsletters, and our public-facing data dashboard, where you can see the trends of substance use disorder stigma across the Commonwealth. All of this work is constantly being refined by our performance metrics, direct feedback from the community, and our Community Impact Committee, as well as conversations with our partners throughout the state. A cornerstone of our strategy is an evidence-based approach called contact-based education. The research, including a significant 2016 report from the National Academies of Science, is clear. One of the most effective ways to reduce stigma is to facilitate positive, humanizing contact between the public and individuals with lived experience. Sharing personal stories allows us to break down the barriers of fear and misinformation. It closes the social distance that stigma creates by reminding us of our shared humanity. Our audience engagement shows that this strategy is effective. Here you can see a snapshot of our top performing content. On the left, our education-based social media content has a massive reach. The post explaining that naloxone is now sold over the counter reached 207,000 people and garnered over 420,000 impressions. On the right are examples of our testimonials from Pennsylvanians. Anthony's personal story was viewed over 110,000 times. Lori's story of being a caring daughter was viewed over 62,000 times. These aren't just numbers. They represent moments of connection and understanding that ultimately chip away at stigma. The qualitative feedback is in many ways even more powerful than the quantitative metrics. We see comments of solidarity from the person who goes by the name of JCG 1510E, who shared that they and their father have over 100 years combined time in recovery. We see expressions of grief and empathy from people like Jane L., who lost her daughter to addiction, and we see organizations using our content to spread the message that addiction is a medical condition deserving of treatment, not judgment. This is where the digital campaign fosters real recovery. Looking at the aggregate numbers from our most recent campaign year gives us a sense of our scale. Over this year, we generated 9.9 million impressions through our social media content, and our videos were viewed more than 2.3 million times. Through these activities, we reached more than 1.9 million Pennsylvanians across the Commonwealth. Beyond digital reach, we are building sustainable infrastructure for change. We engaged with 205 community partners who are committed to spreading stigma reduction messaging, and our online influencers help us garner another 161,000 impressions. We also added 36 new courageous stories to the Life Unites Us story library, which is a living testament to the reality of recovery. I'm now going to turn it over to Erica Saylor, who is our research associate here at the Pollock Center, so that she can tell you a little bit more about our collective impact in the community engagement area. Erica?
Thanks, Weston. Hi, everybody. So as Weston mentioned, a cornerstone of this project is community engagement. We're not just a media campaign. We utilize a collective impact strategy for our growing network of community members and organizations. Our role is to provide the tools, the data, and the platforms to help align and integrate everyone's actions towards this shared goal of stigma reduction. Through our community engagement efforts, we provide offerings to help assist our partners. A great example is our annual toolkit for National Recovery Month, which helps organizations across the state celebrate recovery and unite others to share their stories. Other items we offer also include our Community Award Grant Program, our Community Impact Committee, our data portal, which houses all of our quantitative data that folks can readily access, webinars, our community building workbook, and also our newsletter, among others. Additionally, we're excited that this year Life Unites Us will be working with our partner, the Public Goods Project, to launch an initiative with Public Good News, a nonprofit newsroom dedicated to community health. PGM will be producing and distributing accessible, non-stigmatizing health news in both English and Spanish. They will feature local organizations doing great work on the ground and host roundtables with journalists to improve the way substance use is reported in the media. Another vital component of this project is our research. The entire initiative itself is evidence-based, and we employ a mixed methods research protocol that includes comprehensive literature reviews, large-scale quantitative surveys of Pennsylvanians, and in-depth interviews to capture the nuances of stigma, as well as Project ECHO pilot studies that have focused on community members and also healthcare professionals. This rigorous research ensures our messaging is not based on assumptions, but based on data. And here's some evidence that our approach is working, which is really exciting. These data displayed on the slide are cross-sectional, and our results imply correlation between various measures of stigma and beliefs. This table shows statistically significant differences in attitudes and beliefs between Pennsylvanians who are aware of our campaign versus those who are not. 62.2% of campaign-aware folks agreed that people can get better with treatment, a full 11 percentage points higher than the non-aware group. We see an even larger gap in knowledge about medications for opioid use disorder, with the campaign-aware group being almost twice as likely to agree that the drug naltrexone is an effective treatment. Most encouragingly, we see this translate to behavior and social acceptance. Campaign-aware residents are more willing to obtain naloxone and significantly more willing to have a person with opioid use disorder as a neighbor. These data demonstrate the campaign is achieving its goals of changing knowledge, attitudes, and behaviors. I invite you to be part of our network. Please connect with us. You can follow us on our social channels on Instagram, X, Facebook, and YouTube, or visit our website at lifeunitesus.com to explore the story library, find resources, access our data portal, and so much more. This work would be impossible without the collaboration of our project partners and the dozens of community partners who you see are on the screen here. And again, the support of the Pennsylvania Department of Drug and Alcohol Programs. Thank you. It's now my pleasure to introduce our next speaker, Ashley Narvaez, Program Manager at Shatterproof.
Thank you so much, Erica and Weston. I'm so happy to be a part of this conversation today. So I'll dive into during my section on language guidance, but before doing so, I would love to just take a second to introduce stigma. This is a term that we're all very familiar with. So just to provide a brief refresher, when we think about stigma, it's helpful to think of it as a process that is socially and culturally constructed and reproduces inequities perpetuated by the exercise of social, economic, and political power. In the diagram below, we see how this process takes hold. So we start with stereotypes, which are oversimplified beliefs about a certain group of people. And when those beliefs are accepted and internalized, they turn into prejudice and begin to elicit negative emotions when we think about a certain group of people. That in turn drives discrimination, which really is where we get to the harmful behaviors that cause exclusion. And I start this conversation with reviewing this process as a segue to language, because language is such a powerful tool in creating and starting that process. So it's one of the main ways that stereotypes get created and reinforced. Language surrounds us in everything that we do. It creates how we view the world and the beliefs that we hold. So when we think about the way that people talk about substance use disorder, I've included a couple examples below in terms of some of the most stigmatizing frames. Terms that imply a moral failing can foster judgment and a sense of blame rather than recognizing a person's full humanity. We have direct impacts to treatment and care. So stigmatizing language and medical records can lead to negative attitudes and less effective care from healthcare professionals. We also see internalized stigma. So repeated exposure to negative language can lead individuals to internalize these beliefs, negatively affecting their self-worth and motivation to seek help. So we see that stigmatizing language can cause real harm to others and has a lasting effect on a variety of aspects of a person's everyday life. But the good news is that small shifts in language can help break the cycle and shift the narrative around substance use disorder. So where do we go from here? During the course of this presentation, I'll talk on 3 different strategies and themes that we can keep in mind when we're talking and writing about substance use disorder. So the first, person-first language. When describing people who use drugs or people with substance use disorder, we'll talk about framing as well and centering hope and healing. And we'll close off with the power of shared narratives and centering lived experience. So starting with person-first language. Person-first language is a neutral and non-judgmental way to talk about someone with a medical condition. It highlights that the medical condition is just a part of who they are. It does not define who they are. And I'll go into some examples in the next slide, but just to give you a taste here, using words like a person with a substance use disorder really reinforces that SUD is a medical condition, and then also takes the emphasis away from more stigmatizing terms such as addict. Then when we talk about words like person with lived experience and person in recovery, we're highlighting expertise, we're highlighting the journey that these folks have been on. And again, it takes away from highlighting more of the moral deficits that we often hear when we think about substance use disorder. And we see that shifts in language do work. So people that are exposed to person-first language are less likely to say that a person with a substance use disorder is responsible for their medical condition and less likely to recommend punitive action. So how do we weave this into everyday conversation? So some things to keep in mind when speaking about people with lived experience, again, always emphasizing their full humanity, which includes some of the relationships, interests, and hopes that they might have. So an example here, Kaylee is a wife and a person who has lived experience with substance use. So we are saying that Kaylee has SUD, but we're also highlighting that she has a lot of supportive relationships in her life. The next one, using language that highlights treatability. Sarah used MOUD, a safe and effective treatment pathway to support her recovery. Medication for opioid use disorder is the gold standard for treating OUD, yet it is still very highly stigmatized. So when talking about SUD, really highlighting the treatment options and then also highlighting their safety and efficacy. And lastly, recognizing that each person's journey is unique, right? We know that recovery is not linear, it's a journey, which means that, people take time and different approaches to achieving it. So like many other people with SUD, Tim's recovery took time. Another slide with a few examples here for you all, using terms like relapse, lapse, slip. This is one that, is very common for folks. And what it does is really highlight feelings of shame and error, signifying breaks in recovery rather than highlighting the progress that has been made. And also recognizing and normalizing that recurrence of substance use is a normal part of some people's recovery. So alternative phrases to use would be recurrence of substance use. We also see clean and dirty a lot, especially within medical settings. Terms like clean, dirty are used and associated with filth, not something that should be used to describe a medical condition. So non-stigmatizing words that can be used are substance-free, no longer using X substance, being treated for substance use. Not sure why that text is upside down. That should say a note on self-identification. So really just want to close off this person first language section with just a small note that that language and identity are deeply personal. So when we educate and encourage the use of non-stigmatizing language, what we're doing is establishing best practices for the general public. We are not telling people with lived experience how they should identify. We are not here to police their language. In some circles, there are certain terms that have been used in terms of empowerment to reflect their journey, right? But what we are here to do is just lay the groundwork for what lay people should be using in their everyday language. So moving on to framing for good. In its simplest form, framing can be described as how we package information, right? So framing is the choices that we make and what we emphasize when we deliver a message, how and what we choose to explain, and what are the things that we leave unsaid. So many common existing story frames that are out there do not really reflect the full complexities of SUD, and they may introduce and reinforce existing stigmatizing beliefs. So I'll cover a few on this slide here. The first one, and one that is very common, is victimization, right? So when you hear stories about people with substance use disorder, you hear terms like suffering and struggling. And what these terms do is that they elicit feelings of weakness or pain or helplessness, when really what we want to do is highlight hope. And so using terms like is being treated for could be a really great replacement to this frame. Another one is treatability. So framing SUD as curable or incurable, which really is an all or nothing approach. What we want to do instead is talk about treatment pathways available that highlight the progress that individuals can make. Myth busting is one that sometimes surprises folks. So the idea of saying, do this, don't do that. And the idea behind this is that when you're presenting a messaging with that, you are still framing the action that you don't want folks to take within that message and within their frame of reference. So really what we want to frame and what public health communication best practices tells us is that instead we want to explain, here's why we do this. Recovery only is the last one I'll cover on this slide. And this is all around framing recovery as the ultimate solution. And what we risk doing in this situation is really assigning someone's self-worth to their recovery status, which in turn can, create a lot of barriers for folks that are still seeking recovery, further stigmatizing people who use drugs. And that's not what we want to do. Instead, what we want to focus on is, recovery status does not define value as a human being. I'll briefly touch on imagery next. Stigmatizing imagery can reinforce negative attitudes and beliefs about individuals with SUD. It can also be incredibly triggering for folks with lived experience. Again, I apologize for the upside down text on here. But what this is meant to be doing is that we have two sets of pictures here, both highlighting treatment, right? On the set of pictures on the left, we see someone who looks a little withdrawn, looks a little standoffish. There's a lot of social distance between them and what we're assuming is their treatment provider. We're also seeing someone who's, by themselves in a dark room. There's, feelings of helplessness. These pictures don't elicit any feelings of warmth. On the contrary, on the right, we see folks, with close social distance. They're holding hands. It seems like they're surrounded by supportive groups of people. So both of these are, can be used to portray treatment, but they go around very roundabout ways, different ways to do so. So again, just thinking about the imagery that we incorporate into the work that we do and how it can evoke different emotions in folks. And I'll close off my section with just a brief mention to the power of storytelling. We are all storytellers in our own ways. To really highlight and center lived experience are like important themes to keep in mind, as well as messengers. So in centering these stories, we really want to talk about feelings of hope, healing, strong character, accomplishments, and supportive relationships. And in terms of the messengers that we want to use, always making sure that we're centering people with lived experience, their friends and family members, as well as experts, professionals in the field who can offer some of that expertise and share the same knowledge. And I'll close off with some key takeaways. So auditing your own language, identifying any outdated and stigmatizing terms that you might be using and replacing them with person-first alternatives. Editing with a stigma-free lens. So committing to reviewing the language you're using, the framing and imagery that you're using, great terms to use. And then the last one, and I think the most important one, is sharing your knowledge. So adopting a practice of explaining which terms you're using and why, especially to others who may not be familiar with the neutral, non-judgmental language, and really the way that we can, shift narratives and continue to educate folks. Just a quick slide on resources, which, I'm sure you'll all get in the PowerPoint later on. But with that, I'll pass it off to Hannah Webster, a health reporter at Pittsburgh Post-Gazette.
Thanks, Ashley. That was great. Awesome. So thanks everyone for being here. So I am going to, some of you may know a little bit about this already in terms of the current drug landscape, what's happening within the recovery community, especially if you work with people who use drugs or people in recovery. But I'm going to go over briefly just a little bit about what I've learned in my reporting and just best practices for reporting and communicating with people who use drugs. I've been at the Post-Gazette since August of 2022. So this is, an amalgamation of knowledge from about 3 years of my time in the field and writing stories. So first off, sort of a snapshot of what we're seeing in the drug supply. Fatal overdoses from opioids are decreasing. I think it was about 20, don't, fact check me on this, but I think it was about like a third, it decreased by a third. And experts are attributing a lot of that to widespread naloxone, widespread Narcan availability and use. And that's great. There's still a lot of work to be done. And since I've started at the paper, we see fentanyl increase in the drug supply. And we're also seeing xylazine, a veterinary sedative not meant for human use, and medetomidine, which is said to be 200 times stronger than xylazine, enter the drug supply, the illicit drug supply. There's also a lot of variation in the drug supply. There's sort of patchwork nature. So recently we are seeing a plastics preservative called BTMPS, also not meant for human consumption. Oh, I'm seeing, can others see the slides? Are y'all seeing my slides right now? Yes? Okay, great. Thank you. So yes, PTMPS, not fun substance. It's really not meant for human consumption, never really been tested on humans before. This is showing up in the supply, including in Pittsburgh. We're also seeing a lot of what we call cane drugs. So that's procaine, lidocaine, tetracaine. These can be sedating. They're causing maybe some seizures, and some bags, at least that Prevention Point Pittsburgh test, there can be between 4 as many as 12 substances in one supply. So this is really impacting the way that people who use drugs, just the experiences that they're having. So withdrawal might be quicker, especially with fentanyl. They might be a lot more sedated than we've seen in previous years. They might have wounds from xylazine or medetomidine. And medetomidine, we're also seeing that medetomidine withdrawal can be fatal. There is a Philly harm reduction group that said they've already seen fatalities associated with this, and Prevention Point Pittsburgh said that they're seeing medetomidine in most of the lab results for the Pittsburgh area. That was from September 15th drug checking. So not only is there variation in the drug supply, but there is a high incidence of polysubstance use. So in 2024, last year, 41% of fatal overdoses involved a combination of stimulants and fentanyl. So people likely aren't using one substance. They may be using more than one. So these are just all things to keep in mind when we're working and speaking with people who use drugs, is they have really varied experiences, and there may be multiple substances. There may be a lot of kind of nasty withdrawal symptoms happening that are impacting their daily quality of life. There's also been a lot of drug scheduling changes happening. So 7-OH is sort of thought of as a synthetic opioid, or sort of an opioid-like substance. It comes from kratom, and it can be extracted and sold in smoke shops, completely legal, but some people are saying it's causing like opioid-like withdrawal. And so the Food and Drug Administration recently moved to try to schedule that. Xylazine was also scheduled. Shapiro wanted to schedule 3 to curb supply of it. And then, there are people in the harm reduction space who believe that scheduling is only sort of pushing a drug out, and then a new, more dangerous drug will eclipse it. So we saw this with heroin, fentanyl coming on the scene, and xylazine being scheduled. That's right when we saw the rise of medetomidine, which is stronger than xylazine, excuse me. And then cannabis, we're seeing wanting to move cannabis from Schedule 1 to Schedule 3. So these are all just things happening sort of, if we're looking, like Stephanie said, bird's eye view down, some things that are happening in the opioid and the illicit drug space. Shapiro has allocated millions of dollars to in his budget proposal for substance use disorder, and that has been for multiple years now. So there is money coming in for substance use, and we get the opioid settlement dollars as well, although we've seen a lot of funding cuts federally for recovery support organizations. Unity Recovery and Sage's Army in Allegheny County have all experienced funding cuts. And then I know in Philadelphia, Savage Sisters and the Everywhere Project have experienced financial problems as well. Savage Sisters lost their brick and mortar location, and then there's some pushback on doing harm reduction during the day. So their schedule is now completely during the nighttime, which, as you can imagine, is very difficult. So there's a lot happening. People in the harm reduction and recovery space are always sort of working really hard to make sure that people in recovery and people who use drugs are getting resources. But, as I'm sure a lot of you know, it's sort of a constant battle. Another thing that I have covered recently and sort of discovered is infighting within the recovery community. So when I went to International Overdose Awareness Day back in August, I think it was, August 29th, I noticed a fracture in the parent community. So basically the chief disagreement is that some parents view their child's overdose and death as a murder or a homicide. They insist on the terms poisoning or overdose, insisting that, you know, their kids didn't know what they were taking and therefore it's a poisoning. Whereas, you know, there are other families that are sort of more in the social services recovery place that understand that addiction is a disease and they are advocating for stronger social services. So I spoke to one mom who said she's lost relationships over this debate. She had to leave Facebook groups. But, you know, for the parents who, thanks Olivia for posting that. For the parents, you know, all of these families have lost children, which is, you know, so tragic. And so some parents are approaching this and approaching sort of activism in really, really different ways. So it's something important to keep in mind that even the families of people in recovery or, you know, families who have lost loved ones, they might think really differently about what happens to, you know, their loved one and what the best course of action is moving forward. Tips for combating stigma. Ashley touched on this a little bit, but some things I've learned in the field, your sources are the experts in their experiences. So, you know, you may come in with some things you've heard about what's happening in the drug supply or, you know, some preconceived notions, but as far as the person that you're speaking to, the person you're interviewing, you know, they know what they've been through, they know what's worked for them, and that might not be what you expect. So when I go into an interview, I think about trying to learn from them and trying to just, you know, really hear their story and see, you know, what I can learn. Another important issue is to recognize the systemic issues that got a lot of folks here. So many people who use drugs may be struggling with housing, poverty, domestic violence, or abusive relationships, systemic racism, or, you know, trauma that could be childhood trauma, sexual trauma. There's a lot happening here. There is an intersection, although, you know, it's of course not one-to-one of being unhoused and using drugs. But, you know, of course it's not, there are, you know, there's nuance everywhere, but there are a lot of systemic, you know, things happening that could be impacting the way that people, you know, speak, the way that people are present in a certain situation. You know, like I said about fentanyl, they may be experiencing withdrawal really, really quickly. So, you know, if it's within a 2-hour period, they're, you know, like, hey, I am having a bad time. You know, this might mean when we're interviewing, you're having them like, do you want to take a break? Do you want to not touch that subject? Like, just treating these folks with like a little bit more care and recognizing there may be trauma there. Ashley had a great, you know, presentation about this person first language. You know, I am not saying in my stories that someone is an addict. You know, I'm saying a person who uses drugs or a person in recovery. And then data to bolster findings. So stories are super powerful, but there's also a lot of data out there, and that can, I think, provide a lot of important context for what we're seeing on a larger scale. So, you know, you have the granular view of maybe what 1 or 2 or 3 people are experiencing on the ground, and then we have how this is impacting an entire community, and that can really provide a lot of context for understanding trends. Trust building is also really important. So consistency is key. Continue to show up for these communities. You know, they don't want to feel like, you know, you're just parachuting in or that you're there to get something. You know, building relationships is really how people, you know, open up and come to trust you. And so I found that to be really helpful, like calling places and visiting places like, you know, shelters or recovery clinics multiple times, and just, you know, strengthening relationships with treatment providers, with people who, you know, do harm reduction. You know, they're not just sources, but they're like people who I'm in constant contact with. I also like to be transparent about my process. Not everyone knows, you know, what on the record, off the record background means. They don't know where, you know, their quotes are going, if I'm taking photos, where the photos are going. So I try to be really open about like, here's what this means. Is it okay if I take notes? Is it okay if I record? These are just for my, transcript purposes. Here's where you can expect to see it. And then I try to follow up. Most people have a phone, so I give them my card or I get their phone number, and then I'll send them the story, and I'll tell them, keep my number, save my number if you see something change in the drug supply, if there's a sweep, if there's anything happening that's relevant that you want to tell me, like, I'm here. And I found that to be helpful. And then be on the ground whenever possible. So I wanted to provide an explanation for this. Last year, when Shapiro scheduled the xylazine to be Schedule 3 from being unscheduled, I wanted to really understand what the harm reduction community and people who use drugs who actually take xylazine, like, how would this impact them and what did they actually think about it? So, the news cycle is quick, and sometimes I'm on tight deadlines of an hour or 2 hours, but whenever possible, I like to be on the ground and hear directly from these people, because it really provides context and it humanizes the story. So I could have just called legislators and searched social media for a statement, or pulled from a press release, but I went to a recovery center and I sat down in the rec room where Sandman was playing on the TV and people were eating donuts, and I just sat down and they were like, what's happening? And I was like, I'm just here hanging out. And eventually I like, once I got to talking with a few people, then I would ask them, like, what do you think about this? Do you think this is going to help or harm your community? And a lot of them said, we don't think this is going to do anything good. Scheduling only leads to more dangerous things coming into the community, or if you're dependent on xylazine physically already, then cutting that out immediately can feel really bad in terms of withdrawal symptoms. And so here's another example of that. Elliot Henry was a 31-year-old from Osceola Mills, Pennsylvania, a really small town sort of near State College. And he struggled with prescription pill use in high school. That was an area, sort of rural Pennsylvania, that was flooded with OxyContin during that time, like the early aughts. He had about 10 years of addiction, and he tried so many things. Like, he went to rehab multiple times. They even, he was arrested and they sent him to drug court. He went to a recovery house. He had the support of his parents, which not all people using drugs have. So I wanted to use this story as a way to discuss sort of the broken system and the way that the system can still allow people to fall through the cracks, even when they're trying everything, even when they want to get better. And so what I did was I reached out to his parents. They were, of course, dealing with a lot, but they did agree to speak with me. I visited his hometown and I visited his gravesite. And then so he actually died of a fentanyl overdose in a recovery house in Pittsburgh, an unlicensed one. And the owner of the recovery house agreed to have an interview with me. She showed me the house. And I actually sat in on meetings with the people who lived there. And so I really got to, embed myself in this story and learn who Elliot was, what were the things he was dealing with. I found out that he was employee of the month a bunch of times. He was an extremely hard worker. Like Ashley said, there's more to when someone is using drugs, there's more happening than just that. They have strong relationships. There's things that they love to do, right? And so being able to write a story where I got to learn all about Elliot and the people who loved him, I think it provides sort of a snapshot of the recovery space and how people deal with addiction, and sometimes how the system fails them. And so those are some of my tips. I hope that was helpful. If you have questions or you want to reach out, if you have tips, anything like that, here's my contact information. And then I see in the chat some folks are saying they're unable to read the stories. We do have a paid subscription model, but little trick, if you go to the Wayback Machine, it's an archive site, and put the URL in there. So a lot of these stories have been archived, and you should be able to read them that way. Great, okay.
Thanks, Hannah, very much, and to all of our presenters as well. So now we're going to move into the Q&A for about 10 minutes or so. And the way we'll do this is if anybody has a question they want to ask to a particular presenter, just simply come off mute, identify yourself, who you're with, your title, and then also who you want your question to be directed to. So with that, like I said, if you have a question, feel free to come off mute and we'll take them as they come in.
Hi, my name is Deneen Carn with the consortium. I'm a clinical care manager. And I heard one of the presenters said that they have something stronger than xylazine, but I didn't catch the name of it.
Yeah, that's medetomidine. Whoever has, yeah, I'll go to my slides and then you can see it on the slide. 1 second. Should be here. medetomidine.
Now, does this also cause wounds on the body as well as the xylazine?
I'm not sure if it's the same kind of wounds. Someone in the recovery space may know more. There's someone in the chat who had a definition of xylazine in there. So yeah, I'll defer to experts on that.
And then do y'all know when this new drug occurred in the opiates? Because I know xylazine came out. Do you know when it came out, when it started being in the opiates?
Yeah, so I started tracking this in 2023 for xylazine, and then the medical examiner's office, at least in Allegheny County, wasn't tracking it at that time because they didn't even know what it was. And just in the last year, they've started checking it. And then medetomidine is a little bit more recent, like within the last year, I would say. And please, folks in the chat, correct me if I'm wrong on that.
And is this also an animal tranquilizer or something totally different?
It is, I think, a veterinary sedative, but again, deferring to the experts. Yeah.
That's all I have. Thanks a lot for that information.
Of course.
We still have time for a few questions. We have about 5 minutes or so. So again, if anybody else has any questions, feel free to unmute yourself and we will direct your question.
Hi, this is Julie DiStefano from Jade Wellness Center. I'm an outpatient therapist. And Hannah, correct me if I'm wrong, but I thought I heard you say that they're seeing fatalities in withdrawal for medetomidine. Would you mind speaking a little bit more about that?
Yeah, so I think it was the Everywhere Project. I'm going back to my slides 1 second. Okay. Yeah, the Everywhere Project in Philadelphia put out a post on Instagram where they said that they have seen fatalities associated with this. They are, as far as I know, the only place that has reported this. As we know, things in Philly tend to be a little bit worse before they get to Pittsburgh. It's sort of like a westward movement thing. So I don't know how prevalent it is. I haven't done like a lot of research into that yet because I noticed it like last week, but yeah, Philadelphia folks would know a little bit more about that.
Appreciate that. Thank you.
Oh yeah, and then I want to point out something in the chat briefly that Catherine posted because I just noticed this too. There is a new substance monitoring dashboard for Allegheny County. It's never happened before. We've had an overdose dashboard, but we've never had sort of a drug checking substance dashboard before. So for folks in Allegheny County, you're able to see the breakdown of what's in the drug supply a lot more easily than we've been able to see it in the past. And that link is in the chat.
So I want to thank the folks who asked the questions, for your thoughtful questions, and for our presenters for the insights that they all shared today. So that concludes our Q&A portion. And just a few final closeout notes. Number one, we've compiled some communication resources over on our Life Unites Us page. That was the resources that both Weston and Erica shared towards the beginning of the presentation. That link's going to be in the chat as well as in the presentation slide deck. And we're going to be sending that out to all of you after this webinar. Another option you can use is to scan the QR code to follow our short link to that. If you're looking for language guides, in particular in the form of charts that you can quickly refer to, or you want to print out to file at your desk, in your drawer, and pull out for a quick resource, I'd recommend once you're on that Life Unites Us page to go to both Shatterproofs and the American Medical Association's language guides. They're both going to be great resources for you. Again, if you're looking for what words to use, what phrases to use, and alternatives that are not stigmatizing. And the way to get there is by going to that Life Unites Us page again, under resources, go down to communication resources, and you'll see both of those guides linked right there. Number two, we'd greatly appreciate your feedback to this webinar. So please use the survey link in the chat following when we log off. And number three, to wrap it all up, again, we're going to be sending you this entire presentation deck, the full recording of the webinar, and last but not least, that survey link as well. So on behalf of DDAP and the Pollock Center, I want to thank you for joining us for this important conversation today. And finally, just one reminder that please, whether you write about substance use disorder, broadcast, or post online about the disease of addiction, just share a message of hope. And that would be through DDAP's Get Help Now hotline. That's available 24/7, 365, no exceptions. So we know that words have such an impact, and so can this phone number. And that number is 1-800-662-HELP or 1-800-662-4357. So with that, again, I'm Stephanie Dugan, Communications Director here at DDAP. I want to thank you for your attention to this issue today, and have a great rest of your afternoon.
Yeah.